Afternoon, ladies and gentlemen. Thank you very much for inviting us. I'm John Palmer from Northern Hay Clinic. We're a practice of MSK podiatrists in Devon. I provided podiatry services to Commander Training Centre at the Royal Marines for some 20 years.
And I'm Jack Bolter. I'm a graduate in strength and conditioning and sports coaching. I've had the privilege of working with John now for about a year and a half. I just want to say it's a real great honour for me to be here, as I'm really underqualified compared to most of you. So thank you to Martin and thank you to John as well. I'm a second year podiatry student at Plymouth University with Emma Cowley. And I was inspired by John's treatment, and before this I couldn't take part in all the sports that I love due to really stubborn shin pain in both legs.
So hands up if you would agree that any MSK examination should include vascular and neurological screens. Do we all agree? Great. So today our focus is mainly on the vascular, or it is on the vascular. So consider always that PAD, or peripheral arterial disease, might present with other MSK problems in your clinics. So our vascular examinations, and I don't need to teach Granny how to suck eggs, might include pulses, Doppler examinations, and so on.
But the ABPI, that's the ankle brachial pressure index, in your MSK clinics may seem unrealistic due to time constraints or limited equipment.
PAD is rarely seen in younger patients, but obviously vascular pain, exertional pain does present compartment syndromes and PAES, popliteal artery entrapment syndromes. The pathology of these conditions is completely different to PAD, and nothing we present you today will help you with a differential diagnosis. So this is our first take-home for you. Think vascular for all your patients.
Okay, so time for a quick case history. A 60-year-old female patient presented to Northern Hay Clinic. She had taken an antihypertensive for some years, but other than that, she was fit, healthy, slim, and she walked several miles a day with her dogs. And I think it's fair to say that PAD wasn't our immediate suspicion.
No.
But the patient complained of right foot pain, and she'd been to a whole host of clinics, but she still had no real reason or diagnosis for her pain.
Recently, the GP had sent her for some x-rays and taken some blood tests, but there was really no plausible reason for this lady's pain. What she did tell us, though, in the history, was that in the evening, when she got home, she sat down and her foot was really uncomfortable, it was swelling, and she had to take her shoe off. But there were no classic claudicant symptoms, and this is the second point we need you to take home.
So we started our methodical examination. Her pulses weren't palpable, and right foot Doppler sounds were monophasic and a bit gushy, and her skin was thin. Her mechanical issues were addressed with custom orthoses, but the ABPI testing that we did confirmed right limb PAD. I think the left was 0.96, but the right was 0.59.
Yeah. So there we had it. We had a vascular and a mechanical cause to this lady's pain interacting. We wrote to the GP. They referred her to the vascular surgeons, and they were really impressed that we had picked up this early PAD. She was started on aspirins, statins, and she's now being monitored. Normal ABPI values are between 0.9 and 1.4, with each end of that spectrum being arguably clinically more uncomfortable for us.
So pulses, waveforms, Doppler sounds, history and examination, plus the ABPI, what establish PAD suspicions in our clinics, and we would argue that that's the most holistic approach.
Exactly. So we can argue when the ABPI becomes normal, I'm sure we will, or abnormal, but for each patient, look at them holistically, gather all the evidence. Remember, your job is to screen, and if you're in doubt, just refer on.
Yeah, and I think repetition is definitely the key at that stage. And on one more.
No, we need to go on one more, please. If we could. Okay, so a quick anatomy and pathology check. Here we have two arteries. We have a normal artery and an artery affected by PAD. PAD affects arteries that are visible to the naked eye. That's between 1 and 25 millimeters in diameter. So the normal artery has three layers: an internal layer of endothelial cells, a middle layer of smooth muscle cells, and an outer layer of muscle and connective tissue.
So PAD arteries are damaged by irritants such as smoking and diabetes. And what happens is fats from the blood will enter the damaged cell layer, and macrophages will then mop all of this fat up to create sponge cells. Then smooth muscle cells will form a fibrous cap over this like a scab, and eventually this will calcify. So the artery hardens and the lumen narrows. And the end result is that blood pressure in that damaged vessel will go up, and the damage cycle just goes on.
Exactly. Thank you. So, clinical gold moment here. 70% of patients who present with, 70% of patients with PAD will be exhibiting no symptoms. So, PAD needs to be excluded for all your MSK patients. If you don't feel comfortable with vascular assessment, then you need to be asking colleagues or going on some update courses. The assessment skills are very simple and the testing is very quick. Each of your podiatry contacts or physiotherapy contacts or medical contacts with feet and ankles is an opportunity to screen for PAD. Remember, this is your golden opportunity.
So many PAD patients will go undiagnosed until they suffer from a heart attack or a stroke. So no matter what the age of your patient, you have to be vigilant and consider that you could save a life with just a couple of simple screens.
Absolutely.
Now, John always says that MSK podiatrists can be likened to general builders. A good knowledge of the plumbing and of the electrics can help you on your journey to become a master builder.
Thank you. Thank you. So, the NICE guidelines, Emma's thinking, yeah, that's a very John comment. The NICE guidelines. So, Jack, tell us what the powers that be command of us, please.
So, NICE say that ABPI screening needs to be performed routinely on patients with exertional leg symptoms and non-healing wounds.
But also on patients aged 50 or over with a history of smoking, diabetes or hypertension.
And they say that everybody aged over 65 needs to be screened routinely too. So that might be some of your older, more sporty patients perhaps. But I think it goes without saying that patients who are under 50 with diabetes or they're smokers, just screen them anyway, because just use common sense. If you're not sure, then just screen.
Exactly. So, thank you. Now for the reality of ABPI testing in our clinics, and I can see some of you looking pretty uncomfortable now. Testing manually, in my opinion, is clinical mud. Unless you're doing it all the time and you're a vascular specialist, then you're probably going to struggle to acquire those skills. So it's time now for a golden solution.
Yep. So anything that we can use that removes subjectivity, is time efficient and is beneficial to patient care, just needs to be embraced with open arms.
Yeah. So I'm going to skip this because we are running out of time, and we do want to show you how you can perform very easily an ABPI test in your clinic using a messy automated system. Thank you. So this is, this is my colleague Peter McClellan, who couldn't be here today because he's actually a sister's wedding in Belfast. So here's my colleague Peter McClellan demonstrating, just to repeat myself, pressure index test with our messy automator.
Okay, can I have your right arm, please?
I'll move to the side as well so people can see.
First arm for your side.
This is the ultimate delegation. You see, you get him, and I do no work. It's great.
Just relax. Right leg.
So you can really see how quickly it is to just even put the cuffs on. The patient needs not be rested.
Good. And relax. Basically, all the cuffs are going to inflate at the same time. When they reach a certain pressure, they'll shut themselves off. If you want me to stop for any reason, just let me know. Other than that, just stay nice and relaxed. Unfortunately, no talking throughout the assessment, as it can alter the results. But other than that, off we go.
from start to result in 3 minutes and 6 seconds. Great, so we just have the last slide. So,
Yeah,
Jack.
so to summarise then, PAD is likely to be a sign of more widespread disease. That's to say that hardened arteries in the limb may indicate that the same disease process is affecting the heart and the brain. So all of us can screen for early PAD in our patients, and we can potentially avert life-threatening conditions.
So this is a massive opportunity for our profession. Wish we had a bit longer to speak about it, but take the pressure off yourself, apply it to your MSK patients, and that's our clinical goal. Thank you.